Thank you. Thank you to the organizing committee for choosing this abstract for this press program. And on behalf of my co-investigators, my pleasure to share results of cilta-cel autoleucel in patients with high-risk smoldering myeloma, results from the CARPRISM trial. These are my disclosures. So high-risk smoldering myeloma is a precursor plasma cell neoplasm that carries approximately a 50% chance of progression to multiple myeloma in 2 years. And these patients are identified using various previously published criteria. Historically, patients were placed on observation until they developed disease progression, and at which point they would be offered therapy for multiple myeloma. However, in November of 2025, Daratumumab, which is an anti-CD38 monoclonal antibody, was the first agent approved by the US FDA for treatment for high-risk smoldering myeloma based on results from the phase 3 AQUILA trial. And in this study, patients were randomized to either 3 years of Daratumumab or active monitoring. And while this study demonstrated improvement in progression-free and overall survival, approximately 40% of patients still developed disease progression, and rates of complete responses were less than 10%. So this led to the hypothesis of our CARPRISM trial. We aimed to see whether use of CAR T-cell therapy in the high-risk smoldering myeloma space, where the immune system is more intact, would lead to higher rates of MRD negativity without any induction therapy. The rationale was that the immune system is less altered in smoldering myeloma, therefore CAR T-cell therapy would have potentially even greater benefit compared to relapse refractory myeloma patients. We already have some preliminary data from the bispecific T-cell engagers, teclistamab and linvoseltamab, that have demonstrated very high efficacy in patients with high-risk smoldering myeloma in previous studies. The tumor burden is lower in this disease state, and the plasma cells are less genomically complex. Therefore, we hypothesize that efficacy may be enhanced, toxicities may be reduced. And with this one-and-done approach, there really is lack of exposure to standard of care induction regimens, which can be reserved at the time of myeloma progression if these patients ever progress. And this truly has potential to be one-and-done treatment for patients to prevent myeloma in their lifetime. So here's the study design for the CARPRISM study. Patients underwent screening, followed by T-cell apheresis. They were then offered the option of stem cell collection for patients that were stem cell transplant eligible in case they develop myeloma in the future. Cilta-cel was then manufactured, and during this time, bridging therapy was not permitted by design. Patients then received standard doses of lymphodepletion chemotherapy with cyclophosphamide and fludarabine, followed by a cilta-cel infusion on day 1, and were subsequently followed for safety and response assessments. The primary endpoint of this study was safety, assessed by the incidence of DLTs, and key secondary endpoints included efficacy parameters such as response rates, CR rates, MRD negativity, progression-free survival, and incidence and severity of AEs. Here's the inclusion criteria for the study. So patients were included if they met high risk for the 20-20 criteria, defined as having presence of any 2 of the following: an M spike more than 2 gram, a light chain ratio more than 20, or bone marrow plasma cells more than 20%. Or they could have an IMWG total score of 9 or greater using the scoring criteria that's outlined on this slide. And we also chose some select previously published high-risk criteria that did not fit into these first 2 criteria. So those included an evolving pattern of disease, an abnormal plasma cell immunophenotype per the PATHEMA criteria, high-risk cytogenetic abnormalities per FISH, and a monoclonal light chain excretion of more than 200 milligrams for 24 hours for those with light chain smoldering myeloma. Pertinent exclusion criteria, including presence of any slim crab criteria for active myeloma, and we also excluded patients that had a bone marrow plasmacytosis of more than 40%. And this was by design, since there was no induction or bridging therapy permitted on this trial, and this was the first study using this approach in this population. We wanted to limit patients that had high disease burden. Here's the patient disposition. So 28 patients were approached or assessed for eligibility, 22 approached, and ultimately 20 patients were enrolled into this trial and remained in follow-up. Here's a study schema. So the first 6 patients were treated as part of a safety run-in. After the first 3 patients were treated at a lower dose of cilta-cel at 0.5 CAR T-cells per kilogram, there was a pre-planned safety pause, and data was reviewed, and then the expansion cohort or the dose escalation was done at the standard dose of 0.5 to 1 CAR T-cells per kilogram. After that, that cohort of patients also was reviewed by the FDA. The expansion cohort was created and opened at the standard cilta-cel dose. However, during this trial, we also were learning from the relapse refractory population that absolute lymphocyte count elevation may be associated with some neurological toxicities. So we amended the protocol at that time to implement an ALC-triggered prophylactic dexamethasone strategy, and also lowered the dose of cilta-cel down to 0.3 to optimize the risk-benefit ratio. Here's the baseline characteristics. So again, 20 patients were treated, 12 were treated at a lower cilta-cel dose of 0.3 to 0.5, and 8 were treated at a higher dose of more than 0.5. You can see that the average age was 58 years old. About 2/3 of patients had high-risk cytogenetics and met high-risk criteria for the 20-20 model. The overall safety profile is as follows. So no DLTs occurred in the safety run-in cohort. CRS occurred in all patients, but no patients had grade 3 or higher CRS. Infectious events were rare, and there were no grade 3 or greater infections, and these predominantly involved the upper respiratory tract, and all patients received IVIG prophylaxis. Hematologic toxicity was as expected from lymphodepletion and cilta-cel, and all resolved without any delayed hematologic toxicity. And notably, there were no ICANS noted in this study, but we did have 7 patients that developed non-ICANS neurotoxicity, or NINTS, which I'll cover now. Oh. There we go. So 7 patients developed NINTS. 4 out of these 7 resolved completely and comprised of cranial nerve palsies, a known side effect of cilta-cel. The median time to onset was 21 days, and 3 patients had ongoing NINTS at the time of the data cutoff. 2 of these patients had grade 1 movement or neurocognitive symptoms. 1 of these patients, interestingly, had deposition of phosphorylated alpha-synuclein on skin biopsy, suggesting a potential underlying predisposition to Parkinson's disease. And 1 patient had a grade 1 intention tremor during fine motor skills that subsequently improved. Looking at these 3 patients in more detail, so all 3 of these patients had high ALC expansion and elevations in their CD4 to CD8 ratio. 2 of these patients had a higher cilta-cel dose at more than 0.5. Management included high-dose steroids and IVIG in all patients, and then select other interventions such as low-dose ruxolitinib, cyclophosphamide, and intrathecal chemotherapy in 1 patient. And this was not done due to escalating symptoms, really done as a way to prevent further symptom progression and ideally resolve these cases. All 3 of these patients have had improvement in their symptoms, and they currently remain at grade 1. So here's the efficacy data. At a median follow-up of 15.3 months, all patients achieved MRD negativity at a sensitivity threshold of 10 to the minus 6 by next-generation sequencing. The median time to MRD negativity was very fast in 1 month, and it remained sustained in all patients at the time of data cutoff. Similarly, the IMWG response was 100% overall response rate, and 90% of patients had a stringent CR or better. The remaining 2 patients have short follow-up and remain positive on immunofixation, and we suspect this will also become negative with a bit more time. And 12 patients have crossed the 1-year mark and remain MRD negative. And here's the progression-free and overall survival curve. So no patients have developed biochemical or slim crab progression to date, and the median progression-free and overall survival has not been reached. So in conclusion, this is the first study of CAR T-cell therapy in a precursor cancer setting where cilta-cel was used as primary therapy with no induction or bridging therapy for patients with high-risk smoldering myeloma. There were no DLTs in the safety run-in cohort, no high-grade CRS events, ICHS, CAR T-cell enterocolitis, delayed hematologic toxicities, nor secondary cancers. We did see 7 patients with NINTS. 4 of these resolved completely, and 3 patients have ongoing mild or persistent symptoms. All patients achieved MRD negative disease at 10 to the minus 6, which remains sustained in all patients. And this is the first time where you've seen universal MRD negativity with any CAR T-cell therapy in this disease setting. And no patients have progressed to active myeloma at a median of 15.3 months of follow-up. And longer follow-up is needed to determine the durability of response to help inform the risk-benefit ratio of early use of cilta-cel in high-risk smoldering myeloma. Thank you. Happy to take questions.
Thank you so much for the excellent presentation. Julia, do you want to?
As we move on to the questions, a reminder that if you're joining us by Zoom, please submit your questions using the Q&A box. We'll begin with a question from the moderator, Dr. Dumbrava.
Thank you. Before I jump into questions, I just want to briefly summarize, like high-risk smoldering multiple myeloma has been historically just been managed with observation. Like we know that it's going to progress, and sometimes it progresses to symptomatic disease and leads to irreversible organ damage. And even with the recent approval of Daratumumab, which is a CD38 directed antibody, patients remain on treatment for years and continuous treatment, and they do not achieve a deep molecular response. And so what Dr. Nadeem just presented today really explores a fundamentally different strategy. It's a one-time BCMA-directed CAR T-cell therapy to really intercept the disease early on And so the results of the CARPRISM trial really raise up very, very important questions about whether early immune interception could not only just delay the progression, but can we potentially redefine the treatment goals? Can we talk about the word that we are always avoiding, which is the cure for these selected patients? And so that's why this is so important. And so let me ask you, Dr. Nadeem, the first question is, maybe can you explain why this is so effective in high-grade smoldering myeloma versus patients with multiple myeloma?
Yeah, that's a great question, and really is the fundamental question that we aim to ask studying this in this disease state. We know that the immune system is very different in patients with precursor malignancies compared to those that have had several relapses, exposure to numerous lines of therapy, stem cell transplantation, et cetera, which is where cilta-cel is currently used in patients with relapsed refractory myeloma. So I think the intactness of the immune system, the slightly less genomically complex disease, although this is a pre-malignant state, there's a lot of similarities within the plasma cell than what we see in multiple myeloma. So it is not completely different, but I think the immune system is very different, which is leading to such different results than what we're seeing in relapsed refractory myeloma. There's a few things I didn't cover, which I will cover in my presentation. You know, you are seeing also a bit of a different pattern in terms of the CAR T cell expansion that is occurring, the types of CAR T cells that are expanding. So I think this is a totally different ballgame, and that's why we feel that this has, you know, a much greater potential in earlier disease states than later.
Wonderful. Well, let's open up for questions from the room.
Hi, my name is Marcy Landsman. I'm with Cancer Today. Thank you for your presentation. I just have some questions about expected time to progression for these patients who have smoldering myeloma. Your follow-up was how long would it typically take? How many actually would progress to myeloma in context of a treatment?
Yeah, what you're highlighting is a really critical question of risk stratification in these high-risk smoldering myeloma patients. As I outlined, there's several different criteria that have been used to identify these high-risk patients. Some of them overlap, and some of them are very different. And we're still actually learning, you know, how to fine-tune that definition even more, using genomics, using dynamic markers, doing some of these, you know, things I think will further help fine-tune that definition. But if you look at broadly the criteria that were used in this patient population, approximately 50% would progress at that 2-year mark. And we have a median follow-up of over 15 months, and nobody has progressed so far. So obviously it's trending in a much more favorable direction. As I mentioned, even with Daratumumab, despite the benefit that was seen, you know, these high-risk patients still develop disease progression, you know, at that 5-year mark. And if you look at the observation arm of that study, you know, the median time to progression, again, was about 2 years. So that's the expected benchmark with these high-risk patients. And now what we're trying to see is, you know, is this going to lead to cure potentially in these patients based on this results? And previous strategies of combination therapies and a few other potent therapies have also been studied in high-risk smoldering. That does lead to higher response rates, but nothing close to this. And we also know that those patients with those approaches still relapse despite those deep responses 4 or 5 years later. So we definitely need long-term follow-up of this to know how this is all going to play out. But that's the ballpark time to progression for these patients.
Got it. And can you comment a little bit about the patients who still have side effects? You'd said they're low risk, but or low, not they don't affect too much. But like, what does that look like for them day to day? Yeah,
they're all 3 of those patients are, you know, working. They're, you know, living their lives like they were before. There's some mild limitations, whether it be a slight, you know, tremor that one patient has, or slight issue with, you know, fine motor skills in some of those patients. But, you know, they certainly had improvement throughout the course of this, and you know, with some of the interventions that we had done. And I will say that this is a known toxicity profile of cilta-cel. You know, we know this from patients that have had CAR T cell therapy for relapsed refractory myeloma, and we're now learning how to better recognize it, and I think hopefully over time better manage it. Hence the dexamethasone strategies for ALCs and all these things that have been sort of recently started in the last, you know, year or two in terms of management of these patients. So I think we still need to learn a bit more who is that patient population that develops these symptoms across the disease spectrum, because we still see it in about 3 to 5% of patients that have relapsed refractory myeloma that develop these toxicities.
But they're preventing, like they don't have any symptoms. So, but obviously the risk is so high that it's something enticing to the patient because, yeah. So it's sort of a trade-off, I guess, as they, yeah.
That's right.
But they may never, it may never progress. Okay. Thank you very much.
Yep.
Any other questions?
Hi, Alexander Byrne from Genome Web. Forgive me if I missed it, but which assays were you using to measure MRD?
Next generation sequencing.
Great. Do you have any more details on which exactly?
It's adaptive, the clonoSEQ assay. That's the approved one, and that's the one we've been using.
Got it. Thank you.
And just a follow-up question on that. Do you have any other markers that you will be following for these patients?
In terms of efficacy or?
Yes.
Yeah. So they're going to be followed, long-term now for, both progression-free and overall survival. We are looking at CAR T-cell persistence. We have some data in our paper that's coming out later today at around day 100 so far about how many of these patients have persistence and how that may potentially differ from other disease states. We've looked at soluble BCMA, and we'll be doing MRD assessments essentially yearly going forward to see if this is sustained over 5+ years, which is become or increasingly becoming the standard of these types of interventions.
I see. And let me ask you another question. Like, how do you see this fitting in the current treatments and in relationship with the CD38 antibody? Like, what are your thoughts on that?
Yeah, so this is a proof of concept study. This is not an approval finding study. So despite the results, we can't go and prescribe this outside of the context of a clinical trial. But I do think it raises a lot of interesting questions going forward about the power of these types of therapies in this earlier disease states. There's already trials in newly diagnosed myeloma that are using cilta-cel that'll mature soon. So maybe we'll have that as an option in frontline setting in the not so distant future. But I think fundamentally, as you mentioned before, this does change our thinking that perhaps future studies in this space, could lead to curative potential in these patients.
And do you have any potential markers that would select patients who would be more fitted for this versus the CD38 antibody?
Yeah, I think totally two fundamentally different approaches, as you mentioned before. 3 years of continuous therapy with Daratumumab with, essentially zero chance of cure may be suitable for a subset of patients that are, either older or may not want to take on some of the risks that may be associated with some of these, immune therapies. So there's certainly a place for them. But I think over time, as we're seeing data with the bispecific antibodies, now CAR T-cells, and better results from more potent therapy, I suspect the field's going to shift, in this direction. Right now, it's uniform benefit, so it's hard to know if there's a subpopulation within here that benefited more preferentially. But we do have some data from our other studies, patients that have high-risk genomics, especially, that may not benefit as much from the kind of the more classic induction, quadruplet, triplet type therapy. Seem so far early follow-up, but seem to benefit quite a bit more here. So perhaps those even higher or ultra high risk patients, this could be an even better option for them.
Wonderful. Yes, please.
Yeah, Angus Chen from Stat News. Nice to see you again. I had a quick question. You mentioned earlier that the cells in smoldering multiple myeloma and active multiple myeloma aren't so different genomically. I was wondering if you could elaborate what differences there are, if any, between the cells of a smoldering myeloma patient and a active multiple myeloma patient.
Yeah, there's been a lot of recent papers that have come out with genomics of smoldering myeloma from our group. There's been a couple of recent papers from the Miami and Sloan Kettering group as well. So you're seeing, a lot of these genomic abnormalities that you see also in patients that have multiple myeloma. What's really interesting, though, is that, there are some patients with smoldering myeloma, over 90% or so, that have the same genomic abnormalities that we see in patients with multiple myeloma. But in MGUS, those incidence actually appears to be low. So that does seem like it is truly a pre-malignant, pre-cancer state and that MGUS state. And in smoldering myeloma, more than 90% of them have very similar genomics to newly diagnosed myeloma patients. So there's a long list of them to go through, and there's some that are still being defined, but ultimately there's a lot of similarities there. So we think of this really as, although it's pre-malignant, it's really more pre-symptomatic.